I like to do this very informally. And by informally means I'm going to start to discuss various things, but I like to keep a dialogue going. So there are going to be questions that will come up as I'm speaking, and the best way for me to know about that is, and we'll bring it out. What I'm not going to do is I don't want to discuss individual cases. Okay, and in all fairness, I'm not anybody's physician other than one person in the room here who I have met. So I really don't want to go into individual cases. That you need to review with your own doctor. So we're going to talk in generalities about a number of things, because, and also, this group is a very mixed group. And big differences between what you might do with someone with aplastic anemia versus what someone you might do with myelodysplasia. So there's all sorts of issues in this regard. So with those ground rules, and also the fact that not knowing most of you in the room, I don't know what your background is. And I may be talking to people in the room who know more about the subject than I do. And I may be talking to people in the room who know a minimum amount of the subject. And sometimes it's very hard to keep it level so that everybody's on the same plane. What I want to do is deal with principles. And unfortunately, if I'm under your level of knowledge, if I apologize, if there's a question that I have raised that maybe you don't quite understand, let's deal with that at the beginning, because it may have an impact on what you get out of the whole thing later down the line. All right? Good. All right. So, as you heard, that's my background. Half my background is dealing with chronic leukemia, and we'll put that aside. The other half, in terms of marrow failure syndromes, my interest is primarily in the congenital marrow failure syndromes. These are the ones that you may be born with, that the kiddies get, and that are followed primarily by the children's hospitals, but when they reach the age of 18, they're declared persona non grata. It's sick kids, and I inherit them. So it's a matter of continuing these people for something for the rest of their life. Aplastic anemia, for instance, is spread all over the city. I don't deal with much myelodysplasia firsthand, although I have maybe 100 odd myelodysplasia patients. But usually when they require treatment, I refer them to one of my colleagues at the hospital who specifically gives some of the therapies you've heard about in terms of the myelodysplasia. What I do is transplants. Let's discuss what I mean by transplant, because there's a lot of misconceptions about that whole concept. So what do we mean by a transplant? Well, first of all, we are transplanting stem cells. So some people say, well, if I can't have a bone marrow transplant, can I have a stem cell transplant? What we're talking about is the same thing. There are different sources of those stem cells. Those stem cells may be taken out of a bone marrow, or they may be taken out of the blood. So, but it's the same thing, it's that stem cell. There's also two types of transplants. One we generally call autologous. This is the type of transplant you get when you get your own stem cells back. And this is relevant for a number of diseases out there, such as lymphomas or myelomas. But for the diagnoses that are encompassed by this group, it doesn't apply. So if you're thinking, well, I have aplastic anemia and I want my own stem cells, no, you don't. Because something's happened to your stem cells already, so you don't want to take out bad stem cells and put them back in. Allogeneic transplants are the other form of transplants. This is where you get stem cells from some type of donor. Now, that can be a family member, a sibling. That can be an unrelated donor off the registry. That can be a cord blood from one of the cord blood banks. Or now, that's something we call, that's becoming a little more obvious, is something called a haplotransplant. And these, in fact, are half-match transplants, which is, in the near future, is going to expand the donor availability in a case like this to more than 90% of the population who needs it. So things are really changing. And in some cases, those could be bone marrow, and in some cases, those can be peripheral blood stem cells, and we'll discuss why the difference. All right? So the first issue, what are we trying to do with a stem cell transplant? Well, the first and obvious answer is we are trying to take healthy stem cells from a source and give it to an individual whose stem cells have either pooped out or not functioning properly, such as the case of myelodysplasia, and replace them with something which is healthy and viable. One thing. The other thing we're trying to do, and this is more relevant to individuals who have myelodysplasia than aplastic anemia, is we're trying to give the recipient a new immune system. A new immune system that is going to fight the underlying disease. So this is used in conjunction with preparative chemotherapy and other things to actually fight the myelodysplasia or fight the leukemia for whatever the transplant is there. Now that becomes a bit of a two-edged sword because the anti-leukemia or anti-myelodysplasia effect comes from a type of cells which also causes one of the major problems with this type of a transplant, and that's something we'll discuss in a few minutes later on, called graft versus host disease. Now if you're an individual with aplastic anemia who needs a transplant, you don't need a new immune system. You just need some healthy stem cells to replace what isn't working. So you don't want that side effect one little bit. But if you're someone who's getting a transplant because you have a malignant or a pre-malignant situation, you actually want that transplant to try and work to permanently get rid of what the underlying problem is. So not having the graft versus tumor effect or the graft versus leukemia in a case like that is not good, because the chance then of your underlying problem coming back after a transplant will go up. So everything's a bit of a balancing act. Everybody with me so far? All right. So we're going to go into different types of transplants right now. There are different types. There's the standard, what we call a myeloablative transplant. That is the kind of a transplant where, with a combination of chemotherapy and perhaps radiation therapy, we totally wipe out the recipient's bone marrow. So this hopefully gets rid of whatever malignant disease might be there. 2, suppresses the recipient's immune system so they're not going to reject the donated stem cells. 3, physically creates a space so the new stem cells, when they come into that body, are able to grow. Now, one of the issues with myeloablative is it's a lot more of a heavy-duty transplant, because with this kind of a transplant, we have jacked up the therapy to the point where we now hit the next level of toxicity, which may be something like the gastrointestinal tract or the lungs or something. We push it to the maximum. And that was a problem for many. So people who were less physically well or older individuals weren't able to have a transplant like that because they couldn't survive the side effects of such a transplant. So until 15 years ago, roughly, the upper age of a transplant might have been 50 years of age. That's because when you're above that age, you really couldn't survive everything. Through the work of a group in Israel and a group in Seattle, something called the reduced intensity transplant came in. And what this does is it tones down the amount of treatment that you get. So by that, you reduce the upfront toxicity significant. It suppresses the recipient's immune system enough so that you can put in the source of stem cells. And incidentally, when I say put in the source of stem cells, we're not sitting there and injecting it into the bone marrow. It comes in like a transfusion. It goes in and they start to grow, and slowly there's a balance shift between the person's old cells and the new ones, and hopefully the new ones take over and, in a way modified by the immune system, start to grow. So we totally eliminate the side effects in the first 30 to 60 days that were the downfall of individuals very early and would make a transplant impossible for someone with who was a little less robust. And that's made a big difference over the last 10 or 15 years, to the point now where many centers, and generally, the reason when they asked about where are you from, in Ontario now the upper age of transplant now is about 70. So it's made a big difference. Made a big difference. So that is added to it. So we've now, over the past number of years, as we have many more sources of stem cells. For instance, I was just talking, the International Bone Marrow Donor Registry now is up to about 26 million potential donors. There's 650,000 cords online, and the Canadian registry has now about 365,000, I think was mentioned, potential donors, and it is growing. Much of what happens, though, with, put haplos aside, unfortunately still is that the ability to get a donor is very much ethnically, racially based. So if you're Caucasian, your chances are the highest. Now there's been tremendous moves in the Asian and South Asian population. So, you know, at one point it was a small percentage chance of Chinese, and I was saying when I was in service just a few months ago, more than half our transplant patients on the floor were Chinese origin, getting unrelated donor transplants, just because there's been a major drive in the community. South Asians improving tremendously. Still, if you go to other groups like blacks, it is much smaller. And you get to a place like Toronto in particular, where not only do we have ethnic minorities, we have mixed minorities. That creates even greater problems, because what you need to match an individual is very much genetically based on race and ethnicity. So this is why when you may hear of the Canadian Registry or One Match pushing for drives, and why are they pushing in this minority group? It's because, you know, we're not going to add very much if you put another Caucasian on the registry, but we sure as hell might make a difference if we put a few more people from the Caribbean. So this is some of the reasons why we're trying to solidify things of that nature. All right, so we look for, so the first thing you do is you see your physician, and are you a transplant candidate? Now, someone may be a transplant candidate for a number of different reasons. Number one, the first one is the diagnosis. And if you look around the room, everybody in the room may, for instance, may have myelodysplasia. I don't know what you've got, but myelodysplasia is not myelodysplasia is not myelodysplasia. And it's a very broad spectrum of diseases. And it may be there's some people with myelodysplasia who have slightly abnormal blood counts, where you can actually pick it out, and who are getting nothing other than observation. And there's other people with myelodysplasia whose disease is such that they appear to be evolving into something more acute, like an acute leukemia. That's a very big spectrum. So you first of all have to see, is your disease something that's amenable to be transplanted? Now, there's some very good data out there, and the data actually was published a few years ago by a way of taking an individual and looking at their disease and deciding whether a transplant's an advantage, assuming they had a donor. The study was published by the group in Boston, but it was led by a Canadian who was down there, who we've been trying for years to recruit back to Canada, but we can't offer him what the Boston group has offered him. He's a Montreal boy, actually. And they looked and said, well, there's different ways of categorizing myelodysplasia. There's low risk, there's intermediate 1, there's intermediate 2, there's high risk, which many of you may know about. And he showed that unless your disease was in the higher risk groups, there was no advantage to doing a transplant early. In fact, you may lose, because a transplant is always a balance between the problems you may create and what you may solve. Similarly with aplastic anemia. I've got people who I'm treating with aplastic anemia. All they may need is an oral medication which controls their disease well, makes them transfusion independent, keeps their white count high enough so they don't get infection. And then on the other hand, there's people who have absolutely no blood cells whatsoever, transfusion dependent, have bleeding problems, who may need a transplant immediately. Now, there was also literature at one point that says, well, if you're over the age of 40, transplant shouldn't be the first choice. But that's not necessarily the case anymore. And in fact, given some of the new developments in transplant, it may be just as easy to do a transplant on a 60-year-old as it is on a 30-year-old for aplastic anemia, assuming a donor is there. Now, what you may want to be sure is you want a better matched donor for aplastic anemia to avoid some of the side effects. And you particularly would want a better matched donor if you're an older individual. So that's the first stage, is with whoever's your physician, if transplant is being considered, are you a patient who should be considered for a transplant? And not everybody needs one. And it's not the be-all and end-all for everybody. And it's not something you come in on the weekend and get done and everything is great. It's something that is going to take a while. It's going to have issues that will require follow-up for weeks, months, or even years, and there may be issues following a transplant which may be chronic and permanent. So that needs to be put into the equation. So that's the next thing is, are your transplant candidate? Yes. Then your physician should approach the registry. First of all, approach to find out if you have a sibling match. If you don't have a sibling match, do you have an unrelated donor match? Point number 2, you may very well be a candidate to have a transplant based on your disease. But are you healthy enough to have a transplant? That's the second item. One of the things we're trying to always do is there a way we can minimize the risks to someone having a transplant? And one of the ways we try and do that is, are there what we call comorbidities or other health issues which are going to put someone at risk with a transplant in everything we do? So if someone has very bad, unstable heart disease or bad lungs or has cirrhosis from a liver because they maybe had hepatitis or something, the transplant itself may be enough to tip them over the edge, and they may be enough, in fact, to kill them from these other side effects and not from the problem. So it really becomes an issue, are you healthy? Now, there are things like performance status. You can walk in here, you're living a normal life, you're working, your performance status is 100%. You come into my clinic on a stretcher, and the best you can do is get out of bed or get up maybe to use the bedpan. You're not going to survive a transplant. So the other thing is to try and evaluate how someone is. We go into this comorbidity index, other cancers, heart disease, bad lung disease, significant psychiatric problems that may make it difficult for someone to be compliant with their treatment. All these are important things. So that is the next thing. So this boils down to the 3 features you need to have an allotransplant. You've got to have a donor source. You've got to have a disease that is amenable to a transplant. And thirdly, you've got to be healthy enough to have a transplant. And all those things are very important. And some of those things, such as your health status or your disease status, may in fact change with time. So if someone will say, well, geez, I'm in great shape, I don't want to transplant now, I'll wait till I get sick, you may miss the boat. Because one of the things you want to make sure is you don't, if you're really contemplating a transplant, you have to make the decision before you take yourself out of the game with something that may happen. How do you make a decision to have a transplant? Well, it's not an easy decision. You know, you would come down, we would discuss the whole aspect of it, the pluses, the minuses, how it's done, the side effects. And it's a long, detailed conversation that a patient with their family members come down. And generally, I'll be honest with you, if I don't see someone looking like they're about ready to cry, then I haven't done my job in terms of explaining what the potential side effects are. Because I can't have someone going into this with their eyes closed. Now, I'll have patients say, well, let's just do it. I don't want to hear what's going to happen. That worries me. That really worries me. Because I have to have complete and utter buy-in from the patient. Because now we become a team. The patient, the family, the doctors, the nurses, everybody's support. Every one of us has to work together and be on the same page. We have to be able to communicate with each other. I can't deal with a problem if I don't know about it. And if you as a patient have an issue and you don't think I'm hearing about it, it's not going to get dealt with either. You have to be able to hold. Dr. J, you didn't hear me. Let's go through this again. But I think that's one of the biggest places where mistakes get made is if we're not communicating. That becomes very important. And it's communication with everybody. If you're having a transplant, you have a spouse who you're not filling in on, that you're having potentially a problem, that may not be to your best interest. All right, so we've got a potential donor, we've got a disease, you've got a healthy transplant, someone wants to go ahead. And then it becomes timing. And usually the timing means doing it before other problems occur. And that sometimes is difficult because what may determine when you want to have a transplant? All right, I need a transplant for whatever disease. I've been offered one. Timing. Well, I know if I want to see grandchildren 10 years from now, that's my only hope. So if that is a goal, then you do it and you take the risks. I've got a son who's getting married in March. Well, if getting to his wedding is the most important thing, then maybe I don't want to do something this fall that may eliminate my chance to get to that wedding. So now we get into an area which I as a physician can't deal with at all. You have to deal with it personally. And that is, what are your goals with what you want to do? Now, if your goals are short-term, you don't put yourself at risk with something. If your goals are long-term, well, you have to take a risk in order to get the long-term gains. So as I tell my patients, the decision on having this transplant and when to have it is as much not here, but here. And I've got no tests that can look here and tell you that. But this is the kind of thing that perhaps with close family members, with a spouse, with a partner, you can sit down to discuss and come to an answer to. So all that, you decided to have a transplant, off and ready to go. So questions at this stage of the game. Older or sicker. Because particularly if you're dealing with a malignant or pre-malignant condition, it's just one additional assault you can make on that condition to get rid of it. A reduced intensity, you're trying to make use only of the new immune system to get rid of that problem. Right. With the other one, you're using the hammer to try and get rid of it. So I think for the most part, and for most diseases, it is still felt to be preferable. Between which center you're at, there's different protocols. For the most part, most of us have gone away for the very heavy-duty radiation. Used to be we would give radiation to the point where if you didn't give someone stem cells after that radiation, they would die. Now we use small doses of radiation, and this is a protocol for and I'm only going to speak now for Princess Margaret. We use a regimen that incorporates small doses. And this regimen was actually developed by Jim Russell at the University of Calgary. And it's because it just adds a little bit to the immunosuppression to reduce the chances of rejection. It's not radiation that's intensive enough to cause significant side effects on its own. The transplant will eventually get rid of the cells which produce those antibodies, eventually. But these are cells that can stick around for a long period of time and may potentially cause issues for months or years. To add on it, take it a little further, is when we match, we're matching on the basis of something called HLA, or tissue typing, not blood typing. So unlike a transfusion, you don't have to put an O into an O. With a stem cell transplant, we can take an AB donor and put it into an O patient. The trouble is that recipient always has antibodies against A or AB and produced by something called a B cell. And those B cells can sit around for months or even years. So it may very well be as until the transplant stops those cells from reproducing, but these are what we call long-lived cells, and they may stay around for periods up to a year, year and a half even, to cause issues. So someone who has antibodies, which may make transfusions very difficult, is going to potentially have those same problems during the transplant process when we've knocked the hell out of whatever red cell production that individual has, and it will make it a little more difficult during that period of time. So now we're talking myelodysplasia, and very much the staging of myelodysplasia is also based on the blast count, so that we have something called REB1, RAEB1, which is 5% or less, and then up to 20% when it becomes AML. Generally, it has been our feeling in the past that we will transplant someone with a blast count of less than 10%. Transplanting someone who has a blast count above that kind, we've found has created a lot more relapse. So generally, we would like a treatment beforehand which reduces the blast count to less than 10%. Now, that may be a number of different things. That can be anything from intensive chemotherapy, it can be well, any of the other drugs used for treating MDS that are out there. In my mind, I won't tell a referring physician how to do it. I don't care how they do it, so long as they do it. So maybe that they may try one method, it fails, and go on to a second one. That's fine. If it's a second or third method, it fails, that's fine. Although we may be going to transplants where the blast count is 19%, the chance of getting someone through a transplant and having them not relapse after that transplant is going to be very small. And that's going to be a very low yield transplant. Haploidentical transplants are half-matched transplants. In the past, people haven't done that because there's always the fear that A, it would never graft because your body would reject it because of the half mismatch, or B, the mismatch would be so bad that there would be much more of the side effect called graft versus host disease. There's now been some really interesting work being done, and it's really being pioneered by a group in Johns Hopkins. The pioneer is a guy named Zvi Fuchs. And what he has now shown is using a drug that is 60 years old now, I think, given after the transplant, after the stem cells are given in, that in fact we can reduce an awful lot of the graft versus host disease and the rejection using a half match. So if you're looking for a sibling match, just straight old genetics going back to the days of Mendel and his fruit flies will say that 1 in 4 of your siblings will match you. 2 out of the 4 will half match you. 1 of the 4 won't match you at all. Fine, so it now means half your sibs are potentially matches where they weren't before. 2, obviously, assuming you are the parent, half your kids are all half matches, and your parents are all half matches. So it increases the donor pool tremendously. So what the issue is there's a limited number of transplant centers, particularly in the province of Ontario. In fact, for adults, we're really limited to 4 centers at this stage of the game, and all of which are maximum capacity right now. So if we suddenly start adding transplants, we've got no place to put them. And this is the big myth. It is not as if I need a bed to bring someone in and do the transplant. There are post-transplant issues. Some patients are coming back twice a week to clinics for months or longer. You know, I'm sitting in follow-up clinics right now with 40, 50, and 60 patients. You know, there comes a point where the quality of my care goes down if I have to give you a 30-second once over. So that's one thing. There are post-transplant complications that require readmission. I would want to readmit those people to a specialty institution rather than into the community, where it doesn't matter how good the physicians are out there. This is a unique thing. In the city of Toronto, there's only 4 of us doing this right now, outside the pediatrics. So dealing with the side effects of this is with a very limited number of individuals with the knowledge. So there's got to be a ton of resources, and it's not going to be a quick Band-Aid. This has got to be something that's going to require tens of millions of dollars of money, more hospital beds, more clinic beds, more resources for all people to do all the logistics of it, more doctors. And right now there's a worldwide shortage of transplant physicians, for people who want to do this. I sat around a couple of weeks ago at an international conference abroad with someone from Britain and someone from the United States, and everybody's trying to hire people and they aren't available. Biggest problem with a haplotransplant is that the relapse rate, if it's done for a malignancy, is about 40%. And that's been fairly universal. Well, you don't like the 40%, but if you don't have a transplant, the relapse rate is 100%. Again, perspective. So if you have no other match and can do a transplant where the relapse rate is only 40 and maybe your long-term survival is 30 or 40%, again, transplant-related complications, you tell me what you do. Now, if you're 65 years old and have other issues, that's fine. If you're your age, you know, do you want to hit 20? It's not better anywhere else. The difference between here and Johns Hopkins is Johns Hopkins will transplant you with whatever indication you have, as long as you have the main factor. $500,000 to $1 million to have that transplant. If you've got a prime disease and donor that would make the transplant viable, but you don't have a pot to pee in, you don't get a transplant. That's the difference between the American system and our system. I'm going to expand that beyond 5 years. The biggest developments in transplant are not the super drug or something like that has made things better. They have come to better tissue typing techniques. We get high resolution techniques which will allow me to hone in on a much better unrelated donor. 2, better blood bank techniques. We get much better matches on blood transfusions and things of that nature. Much better work from the Canadian registry in getting transfusion donors out there very aggressively that are matched. 3, better drugs for immunosuppression. So we're getting, you know, 25 years ago, the problems due to bad immunosuppression were tremendous. They're much less common because of the newer drugs. 3, being able to use peripheral blood stem cells instead of bone marrow. In the olden days, to do a transplant, we would have to take a donor and they would have to go to the operating room, and under a general anesthetic, we'd put burr holes into their pelvic bone at the back 50 to 100 times to take out a liter and a half of bone marrow to go in as a transplant. Now, with drugs over the past 15, 20 years, with a drug called Neupogen, which some of you may have used for other reasons, you give that to a normal individual, and what it does is it turns on their bone marrow so that the stem cells suddenly appear in the blood. And we can now, with a process called leukapheresis, hook them up with an intravenous here, an intravenous here, circle things through what's really a glorified centrifuge, take out the stem cells, give them back everything else, and use those stem cells So donors are no longer going to the operating room. So the morbidity for a donor is greatly increased. The enthusiasm for a donor for doing this is improved. And in fact, even in Canada, we did a study a number of years ago. We did quality of life on donors on a randomized study between bone marrow and blood, and there's no doubt who won. So things of this have all been developments. Yeah, there's things like the haplo is a new concept, but there's no new drug there. There are some of the biggest problems we have. We're always trying to look at new drugs, but there's been no home runs in that area in a long time. We also have better treatment, and this is a biggie in the last 20 years. Is one of the problems when you're suppressing an immune system, or you don't have an immune system to begin with, is infection. Despite the fact that we're dealing with superbugs and everything else, and you know, someone who's had a lot of antibiotics may come back with resistant antibiotics, we have a really good armamentarium of antibiotics to treat bacterial and fungal and viral infections that in the past we could not treat very successfully. For instance, one of the biggest infections we have post-transplant is a virus called cytomegalovirus. This is one of the herpes family of viruses. 90% of us in this room have been exposed to it. We may have had something like the flu a while ago. Where is this virus a problem? Well, it's a problem if you get this infection when you're pregnant because it causes birth defects. It's a problem if you have AIDS because it causes problems with the retina. And it's a problem if you've had a transplant, whether an organ or a stem cell, because it can cause very significant infections, including pneumonia and other things. We now have a number of different, now have tests that we can pick it up when it's still just the virus in the blood versus an actual infection. We now have drugs that can work on it very effectively. Things like this have made a big difference. But specific drugs for the transplant, believe it or not, we haven't found any of those. In fact, our success may not be as good today as it was 15 or 20 years ago. Wow. Number one, 20 years ago, it was rare for us to do anything other than a sibling transplant, okay, which were the best. Now we're doing unrelated donors, we're doing mismatched, so all those have additional problems. Two, when I first started out in this game, the top age of transplant was 40. We used to have a joke that the top age of transplant that we would do was proportional to the head of the program. We're now doing people of my vintage. And you know, transplanting someone my age is not the same as transplanting someone who's a lot younger. Three, some of the best diseases that we had to transplant is a disease called chronic myeloid leukemia, which when I first started, it made up 40% of our transplants. Now, science has developed such wonderful drugs. If I transplant one or two of those patients a year, so we have space, we move on to second, third remission AML after myelodysplasia in a 70-year-old, you know, so the population we're transplanting is not as easy. So if you look at our overall stats, they may be no better, maybe even a little worse, but then we're not dealing with the same population. In terms of what are the numbers? You know what? Give me a disease in an age group with a certain type of donor and everything, and I'll give you a number. If you want the overall percentage, if I do a 30-year-old aplastic anemia from a sibling donor, I've got a survival of more than 90%. If I do a 70-year-old myelodysplasia gone into AML, persistent AML from a mismatched unrelated donor, 5 to 10%. So you can't give an answer across the board. Basically, peripheral blood stem cells, actually it's faster than bone marrow, which has been one of the other beauties of peripheral. It's helped shorten things. On average, it's probably somewhere around 3 weeks that things start to grow, which is the first step, is getting through the period of really low blood counts when we have to deal with the transfusions and infections with no white cells to fight it, so about 3 weeks. I had this conversation earlier today with some medicine by statistic. Yeah, okay. The answer to your question is if I talk to a patient, their chances of anything are 0 or 100%, nothing in between. And I cannot, unfortunately, look at an individual and do a bunch of tests which will say whether you're a 0 or 100. I have to look at a population with your particular spectrum of whatever it is and tell you this is the percentage of chance. And that's the best we can do. I think the first thing I think you have to do is change your perspective.
Good idea.
And the reason you change your perspective is if you're being offered a transplant, it is because what is going to happen to you without the transplant is 0, not 30. So when you start comparing 30 to 0, it looks a little better than 30 to what? The 100, which is a lot of people that if I don't have the transplant, I've got a 100% chance. Well, no, you've got a chance that whatever disease you've got is going to kill you from that disease at some point in the future. So you've got to use 0 as your baseline. You're not going to be offered a transplant if you've got a condition that will go on for many years without causing you a problem. I wouldn't offer you a transplant. I'm not trying to be offensive when I say change your perspective, because people don't look at what the comparator should be. So yeah, 30% is not great. 30% chance of dying from the transplant or complications, 30% chance of relapse does not sound good. But
are those numbers? I mean, those are numbers.
Depends on the disease, your age, the type of donor.
Right.
As I said, if I'm saying aplastic anemia and you're 30 years old,
right,
it's maybe only 10% chance of dying from complications of the transplant and a 90% cure rate.
If I went to my physician and said, okay, riddle me this. I'm this age, I'm this, I'm that, and the other thing, predict my chances of success. I should be able to get some sort of...
You will get a percentage.
Right.
And it will, and as I said, you are a 0 or 100, you will get a stat. And it's not that you should go to your physician, you should go to a transplant physician.
Right. No,
Because there's a lot of misconceptions out there in the community by people who don't do this on a regular basis. I've had people who come to me and I've said, oh, yeah, you've got to have a transplant, it's my only cure. Well, they come in and they're on a stretcher and they're damn near dead to begin with, and you know, it's not going to be a cure for you. I'm going to hasten whatever is going on, probably not make things any better. The first aspect is when you're diagnosed is to figure out, are you someone who a transplant will benefit? And this is something that you need to talk with your practitioner taking care of you. Because A, they may say, well, you've got low risk myelodysplasia and doing a transplant is probably not warranted at this stage, or not, or there may be people out there with maybe not enough experience to know about the transplant option in detail who you may have to push them. And I think we still deal with it in some cases that there are still people out there who think that a transplant is the last resort. And it isn't. For many people, waiting till there's nothing else available maybe have waited too long. Okay, so stage. You're a transplant candidate. You've got a stage of disease. The next stage is to try and find your donor. Now, if your brother lives down the block, getting him tested is going to be easy. If your sister is in rural China, getting a sample from that sibling may be more difficult. So particularly in a place like Toronto where people come from everywhere, and we have tight people all over the world. It's not an issue, but sometimes it will take time. It's also as dependent on you if you have siblings to tell them. I get people who I don't want my siblings to know. And they're from a visible minority with the chance of finding an unrelated donor is almost impossible. Well, the best chance is still those siblings. So don't expect me to do a miracle. You've got to go, you know. There's something in medicine called Willie Sutton's Law. Did anybody here know Willie Sutton's Law? Anybody know who Willie Sutton was? Willie Sutton was a British bank robber. And someone asked Willie why he robs banks. His answer was, that's where the money is. And it's a trite joke we have in medicine that, you know, your siblings are still your best match, so you've got to communicate with the family to get that done. Then, if there's no related donor, we start the unrelated donor search. You know, there's some people who are blessed. You go right in and bam, there's the match right there. It takes a couple of weeks, the whole business, identify it. You only have to be sure, as I was joking earlier on, you have to make sure it wasn't you who went on the registry a few years ago. On several cases I've gone in and, right, and they're in Toronto as well, and then I get this call from Ottawa. I hate to tell you, but you've just matched yourself. And someone has forgotten they were on the registry. So at least we know the system works, is my joke on that. So, and there's other people who may take a while to find that match. Okay, so then a donor's identified, you're referred to the transplant center, have a discussion. If I was to see you today about a transplant and you want to go ahead, with our current waiting list, we're talking mid-December. Now, there's been a lot of flack over the past few months, which is in the public press, so this is not secret, based on something that went on in Hamilton of a delay, and that's causing the whole province to be in a turmoil. They're rushing, and we're going to send people outside the province, to the states, all that. And that may speed things up, it may not speed things up. Don't know the answer. So that's roughly the logistics right now. So very much, people have said about how much time it takes from the time of diagnosis to a transplant. But from the time we are made aware of a patient to see that patient, it's roughly 2 weeks to see them and about 2 to 3 months to transplant them. That is the delay. To a limited extent. Because the argument is every time you get someone who's high risk and put them in, you take someone who's good risk and delay them till they can become high risk. You know, it's not easy for us either to be able to look into. So the province has decided that maybe sending someone to the United States may be an option in that regard. So if that shortens things in terms of doing the transplant, if people are given that option, that's fine. If you decide you want to transplant, I tell you your waiting time is December, but also tell if we send you to somewhere in the U.S. because that's now being funded, and it could be done quicker, you will be given the option for doing that. Centers in the U.S. have said they can do it much faster, which is fine. I'll be honest with you, out of about more than 30 patients who've been offered the chance so far since this has come in the last couple of months to go to the U.S., only 2 have opted to do it. There's an issue, you have to phone in and find out what they will cover. Most of the big ticket items are going to be covered. But if, for instance, you want to take your wife with you as a companion, is the living expenses of your companion going to be covered? A health insurance plan to cover if you get hit by a car, your wife gets hit by a car, is that covered? These are all things that we are not party to. There's a hotline you have to phone to find out. Super question. Side effects go up with the age of the patient and the age of the donor, particularly graft versus host disease. And there was a school of thought, particularly in Germany, that you were better off having a 20-year-old unrelated donor than a 60-year-old sibling. So they've actually done that study, and it doesn't hold out. It doesn't make a difference. Now, if I have a 60-year-old sibling and a 40-year-old sibling, and you're in the middle, I go with the 40-year-old sibling. Now, cord bloods are been around for a long time, and we'll deal with cords 2 things. Number one, the myth number 1. Cord bloods are the great donor for everybody. And that was out there for a while, as you don't have the side effects, you can take any cord and use it. Well, we know that's not the case. And it turns out with a cord blood, you have to have at least a 4 out of 6 match. And generally with an adult, you need 2 cords.
2
cords.
2 matching cords.
2 cords that are at least 4 out of 6, with the mismatches being the same ones in order. And what's very interesting is the biology is great, but you give two from two different areas. One of those cords is going to graft. The other one will disappear. It's a helper for some reason. And it's not necessarily the one that has the most stem cells in it when you put it in is going to be the one that takes. So doing single cords in adults is somewhat risky. Why? Well, if you use a related donor and unrelated donor and for some reason the graft doesn't take, you can go back to the source. If you use a cord, that's it.
Right.
You've shot your bolt. So in adults, we tend to want 2 cords, which doubles the cost. Again, unless you married your brother, that cord is only half you, correct? So those companies that are out there in the community saying freeze the cord in case you know it are making, put it bluntly, a shitload of money with a cord that's likely never going to be used. Unless there's some overlap. You know, for instance, if you're Caucasian, then there's some of the HLA antigens or the transplant antigens are very common. So it's possible, for instance, if you're an A3 is one of them, there's about a 30% chance that both parents will have that. You might have a 4 out of 6 out of your child's cord. You might. The results, but still only a single cord.
Right.
And that's an issue. That's myth number 1. Myth number 2 is that cord bloods are wonderful for everybody who doesn't have a related or an unrelated donor. Okay? Well, the National Marrow Donor Program in the United States does a lot of research, and what really they've shown is particularly when you start getting into racial and ethnic minorities, the chance of finding cords that are adequate are not much different than finding an unrelated donor. So again, if you're Caucasian looking for a cord, there's a good chance you'll find it. If you're one of the registries, for instance, now if you're Chinese, there's a phenomenally large cord blood bank in China, and there's another one in Taiwan, and there's a chance you might find something. But for everybody else, it doesn't have. And back to Toronto, if your dad's Portuguese and your mother is Filipino, there ain't no Portuguese-Filipino bank that's going to find you a match. It becomes an issue. And this is horrible, particularly with the kiddies now, where we see that we're trying to find matches in that population. It's tough. Because what you get if you're Portuguese and what you get if you're Filipino in terms of these transplant antigens are totally different. Here's the rationale. When I am going into the unrelated registry to look for a donor, I want a younger donor. Why? Because I have a higher chance of graft versus host disease with an older donor. 2, you may be sitting on that 60 years of age, and when I try and work you up as a donor, I find you have heart disease or something else. Or we found this even with related donors. The older the donor, the more likelihood the donor has the same disease as the recipient goes up. So there's more potential problems with an older donor. 3.
Cutoff would be?
Right now, one match prefers under 35. So, no, males.
Related.
I'm going to get to that.
Related.
No. Mine donor, I've done donors up to 75, as long as they're healthy. Now, males was the other aspect. Now, why males? Well, statistically, it is shown that if the recipient is male, using a female donor increases the chance of problems. See, it's always women that's the problems. Joking aside, particularly women who've been pregnant, and particularly if they're pregnant with male children, believe it or not, when you're carrying a male child, you're creating antibodies against male. So that increases the chance that we're going to put stem cells into a male recipient that may actually contribute to one of the side effects we'll talk about later called graft versus host disease. So it's like O is the universal blood donor, Okay, male is the universal stem cell donor. Okay, if the recipient is female, it doesn't matter. But so we're looking at making donors available to as wide a spectrum as possible. And One Match has a budget for how many people they can test, so they want to maximize the available donors. Secondly, shelf life. You go on the registry at the age of 50, the chances that you're going to be available as a donor for more than a few years is that much. If you go on the registry when you're 17, we're looking 30, 40 years of availability. So you see the rationale is very well thought out from an economic point of view, but also from a biological point of view. So it's not discriminatory, it's done for a reason. Well, generally the average admission to hospital is about 4 to 5 weeks in an uncomplicated scenario. So that's roughly a week getting what we call the conditioning, which is the preparative regimen designed to wipe out the recipient's stem cells, wipe out the recipient's immune system, and get someone ready to receive the donor stem cells. Then there's roughly 3 to 4 weeks where the blood counts go through the bottom, that you're transfusion dependent, you may get infections that require very aggressive antibiotic use and recovery. Then there's the potential for other side effects that may occur. On average, most people are in about 4 or 5 weeks or so, but I've had, super achievers who've been out in 3 weeks, and I've had people who've been in hospital for 9 months. We use what's called isolation, and I'm now talking Princess Margaret only. We have special rooms that are special air filtered, laminar flow, HEPA filtered, with own bathrooms, etc. Isolation basically means you can have visitors who have to be healthy, because we don't want them bringing anything onto the floor, and have to be 9 years of age or older, because younger children carry bugs that are potentially lethal. People have to wash their hands before going into a room. That's our isolation. Patients, if they're well enough, we encourage them when the traffic goes down after hours or in the morning to get up and do laps on the floor, because staying in shape is important. When I first started doing this in Calgary, we used to get into operating room gowns with masks and boots. And it was a big production to go into, and you changed each time you went into a different room. It was a major production to do it. We've learned that the biggest cause of infections are from the recipient's own body or because of dirty hands.